Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Thank you, Ashley, and thanks to the conference organisers for the invitation to present in your beautiful city. It's nice and warm, and it's been an absolutely fabulous experience, so thank you. I've been asked to talk about resuscitation science and how that might relate to emergency and critical care nurses, and I think it's really important that we embark on evidence-informed practice at all levels of practice, but particularly when we look at resuscitation. My disclosures are mostly intellectual. I don't have any financial conflicts of interest that I need to declare. And I think if we go back to basics, the things that the evidence says increase your chance of survival with good neurological outcomes are good quality chest compressions, early defibrillation if it's a shockable rhythm, and good post-resuscitation care. And I think I'll talk a little bit more about post-resuscitation care at the end, but I think that's the space where nurses, emergency nurses and ICU nurses can make a really big difference to patient outcomes. The things we know that will kill you are things like overventilation, poor quality chest compressions, delays to defibrillation and poor post-resuscitation care, and we heard a little bit about some of those things yesterday. So Jerry kind of talked a little bit about this morning and a little bit about this yesterday, and one of the tensions, I guess, in the emergency department when patients have a cardiac arrest is airway management and whether to use supraglottic airway or endotracheal intubation. And I won't go on about this too much because we've heard other speakers talk about that, but you do need to think about the impact on chest compressions. And once an advanced airway is in situ, you can reduce your ventilation rate down to 6 to 10 breaths per minute without pausing for chest compressions, but you do have to have some level of coordination. We know that with breathing, in the first 5 minutes of cardiac arrest, adults maintain an oxygen saturation somewhere in the low 80s, so ventilation's not that important in the first instance. And the focus on uninterrupted chest compression should be the priority. After 5 minutes or so, though, ventilations become more important, and as your diaphragm runs out of energy, and we need to start thinking about what are our strategies around ventilation. We also know, and I think people have talked historically, when I started my training, we would ventilate patients in cardiac arrest to what we thought was a normal ventilation rate of somewhere around 16 to 20 breaths per minute. But what we understand now is that you're actually not in a normal state when you've had a cardiac arrest. You've got reduced blood flow, reduced metabolism, reduced carbon dioxide production. And so even in a low flow state, if you're producing carbon dioxide, it's not going to get around the body as quickly as it would if you had a normal cardiac output. And we know that overventilation is harmful, and these are some of the really early studies. So we've known this for a long time, and they say it takes 10 to 20 years for evidence to make its way into everyday practice, and some of this science is a really good example because we've known theoretically for many years that overventilation is bad, and we know that it reduces blood pressure, reduces coronary perfusion pressure, and it reduces cardiac output. So they're all things that you don't want to have happen when you're in cardiac arrest. We also know that overventilation can precipitate hypotension, and so overventilation is probably an underappreciated cause of electromechanical dissociation or pulseless electrical activity, and particularly in trauma patients with hypovolemia, overventilation is particularly harmful. We know that at ventilation rates over 30, which hopefully we will never see anymore, your intrathoracic pressure never goes under zero. And so that means that your coronary perfusion pressure is never going to get to the level required to give you a reasonable chance of getting return of spontaneous circulation and therefore survival. We've heard some speakers talk about the benefits of waveform capnography, and we know that it's the test of choice to confirm endotracheal tube placement. But we're also starting to understand more now about monitoring during CPR, and we know that elevated end-tidal CO2 levels, or levels over 10, have a correlation with outcome, with good cardiac output, with good coronary perfusion pressure, and with return of spontaneous circulation. So I think one of the really important roles as an emergency or ICU nurse is to make sure that those patients do have end-tidal monitoring in place really early, either post-intubation or if you're using a supraglottic airway, attaching it to the supraglottic airway. Sometimes that's one of the things that's easily missed in the crowd and in the moment. So I think it's a really important nursing responsibility to make sure that that monitoring is in place and to be reporting those values really loudly to the team leader who's running the resuscitation. We know that if you do good chest compressions, you can generate around 1/3 of your normal cardiac output, and if you're really good, you can get systolic blood pressures up around 80 and 90. We know that organ perfusion's reduced during CPR, and we've really come to understand, probably in the last 5 to 10 years, the importance on continuous good chest compressions. We know that the more chest compressions you give, the better the myocardial blood flow, the more ATP or energy that gets to the heart, and your chance of defibrillation becomes more successful. Again, we've known about coronary perfusion pressure for many, many years, but we haven't really translated that into practice probably till the last 10 years or so. And we know that to get return of spontaneous circulation, you need coronary perfusion pressures over 15. And we know that coronary perfusion pressure is cumulative with chest compression. So every time you stop compressing, your coronary perfusion pressure drops down, and you've got to do compressions to then get it back up to those levels where you do have a chance of return of spontaneous circulation. I'd like to thank Mike Parr for these graphics, but this is what used to happen when some of you will remember when we did 15:2 or 5:1 or some of those various ratios where we really weren't compressing for very long at all, and every time we stopped, we lost coronary perfusion pressure. What we're doing now with 30:2 is actually building our coronary perfusion pressure to reasonable levels, and so that focus on chest compressions is really important. But we know that CPR quality is variable even in expert hands, and this is a study of in-hospital cardiac arrest, so you would imagine that it will be mostly doctors and nurses doing CPR, and we see many patients getting compressions that are too slow, too shallow, or the ventilation rates are too high. The other thing we know is that rescuer fatigue plays a really big role in the quality of chest compressions, and we know that rescuers, if we look at CPR feedback devices, rescuer fatigue happens at around 1 to 2 minutes in, but rescuers don't self-report fatigue for at least 5 minutes. So I think this is no time for heroics, and one of the important things for emergency and ICU nurses is to make sure that you're routinely changing the person who's doing the chest compressions. Okay, this is no time to say, I'm fine, I can go for 10 or 20 minutes, because the science would say that you can't. So making sure that you've got people ready to go and ready to refresh that person doing compressions is really important. Judith spoke a little bit yesterday about CPR feedback devices, and we know that that CPR feedback devices during actual CPR, there was no evidence of better outcomes in terms of return of spontaneous circulation or survival. But as Judith really nicely pointed out yesterday, we can't improve what we can't measure. And so having CPR data, even if it's retrospective data, gives us areas to target for improvement. So we can look at the data downloads from defibrillators, from AEDs, from CPR feedback devices, and look at, okay, where are the areas that we need to target for training, and where are the areas that the team leaders need to keep an eye on during real resuscitation. So I think that data is actually very, very useful. And with time, who knows, we might find better outcomes with CPR feedback devices as time goes on. We know that in adults, VF is one of the most common causes of cardiac arrest, and it doesn't revert spontaneously, it requires defibrillation. But the longer we leave it till the first shock, the worse the patient chances of a good outcome are. So again, early defibrillation is a really important strategy for emergency and ICU nurses. So you need to make sure that you've got defibrillators available, that when you've got the defibrillator at the bed, someone knows that it's there, and being a good follower in terms of in the resus team. So making sure that the team leader knows if you've got to go and get a defibrillator, when it's arrived in the resus room, making sure it's applied in a timely fashion, and making sure that we give that first shock as soon as we can if it's a shockable rhythm. The other thing we know is that we need to do lots of chest compressions and minimise interruptions. And we know that the more we interrupt chest compressions, the worse patient outcomes are. And it's really easy when you look at video footage or you look at data from CPR, it's really easy to have lots of little interruptions to chest compressions. And again, I think for the nurses in the room, the person that often has the helicopter view of what's going on in a resuscitation is the person who's the scribe, the person who's doing the documentation. So I think it's part of your role to really look at, okay, how often are we interrupting chest compressions, and making sure you prompt people when they're not compressing to get back on and start chest compressions. So that role, I think, even though you're quite busy writing, you're probably one of the few people in a resuscitation room, other than the team leader, that has that global overview of what everybody's doing. We know that we should continue compressions while charging the defibrillator, and we should start compressions immediately after shock delivery. And we know that that's really important in terms of increasing the likelihood of return of spontaneous circulation. We know that if the cardiac rhythm is compatible with return of spontaneous circulation, then we can check a pulse, but other than that, our priority needs to be chest compressions. Medications, some of our colleagues talked about medications yesterday, and we know that no medication has been shown to improve long-term survival. And I was talking to my colleagues yesterday and I was saying I think they just transfer the location of death. So it means that people in ambulances would die in the ED and people in the ED die in ICU. But I think, you know, as a nurse educator, we've been very focused on medications for probably 15 or 20 years. You know, we take nurses into ALS assessments and we get them to explain the pharmacokinetics and how those drugs work, and we've been really, I think, too over-focused on medications and probably not focused enough on basics like good chest compressions and early defibrillation. So yesterday we heard about the trials with adrenaline versus placebo, and Ian Jacobs' trial, and then Gavin Perkins with the Paramedic 2 trial, and it's going to be very interesting to see where that goes. But I would imagine in our careers we will probably see the demise of adrenaline use in cardiac arrest, so that will be a really big shift for us. But we'll wait for Gavin's trial to finish and see what he finds out. With antiarrhythmics yesterday we heard about Laurie Morrison's group doing the ALPS trial, and there's been certainly other studies that have shown that there's no improved survival to hospital discharge or no improvement in functional survival with the use of antiarrhythmics in patients in shockable rhythms. So again, you know, these trials are really important, and as emergency and ICU nurses, it's in our interest to make sure that we understand that these trials are happening internationally, that we read the literature, that we understand the evidence around some of the therapies that we use in cardiac arrest. But I think post-resuscitation care is really where we could probably make the biggest difference, and we know that post-cardiac arrest syndrome is a combination of brain injury, heart injury, a systemic response to reperfusion, and there may be issues related to the cause of cardiac arrest like ST elevation, myocardial infarction or pulmonary embolus. But we know that good post-resuscitation care can make a significant difference to morbidity but also mortality. And the things we know that reduce the impact of these post-arrest syndromes, so in brain injury, target temperature management, blood pressure control, airway management, ventilation, oxygenation but not too much, and seizure control. We know that myocardial dysfunction can be managed by blood pressure control, and there's a whole lot of strategies that you can use to achieve that. We know that the systemic response to reperfusion can be quite harmful, so again looking at things like temperature control, glucose control, blood pressure control, and if there's evidence of sepsis, early antibiotics. And some of the issues relating to the cause of cardiac arrest might require things like fibrinolysis or PCI. So our current recommendations in Australia are to manage systolic blood pressure greater than 100, to make sure that we ventilate not too much, to make sure that we aim for normocarbia and avoid hyperoxia. And I think one of the issues that I see in the emergency department is patients will come in, certainly in Australia, the patients will come in having been resuscitated with 100% oxygen by the paramedics, and we often continue 100% oxygen in the ED, and we probably do that for too long before we get a set of blood gases and start titrating down our oxygen to a normal saturation. So again, I think, this is one of the places where emergency nurses have a really important role in saying, look, hey, we haven't done a blood gas, we've got return of spontaneous circulation, the patient's saturation is 100, so you don't know how hyperoxic that patient is. So being that oxygen guardian, I guess, is a really key role for emergency and ICU nurses. We want to control blood glucose. We know that the studies, of really tight glycemic control have shown not great outcomes, but our current recommendations are to treat a blood sugar over 10. Targeted temperature management we'll talk about in a second. I think Judith's going to talk a little bit more about that in a minute. No? That's okay, I'll talk about it then, that's fine. We heard yesterday about some of the roles for anticonvulsant therapy. And obviously one of the really important things for patients with ST elevation myocardial infarction is to get them to the cath lab for PCI as soon as we can. And that's a complicated process to transport a patient from the ED to the cath lab, but it's important that we do that in a timely fashion. I'm not sure what happened in Singapore, but certainly in Australia in 2002, we had these two studies coincidentally on opposite sides of the world that showed good outcomes when we cooled people following cardiac arrest to 33 degrees for a period of time. So we started implementing our protocols. The Australian Resuscitation Council amended its protocols in light of this evidence, and we were making some inroads, although we had limited uptake of targeted temperature management, particularly in the emergency departments. So we were making some inroads and we had people on board, and then this study came out looking at 33 to 36 degrees. And what happened in Australia was a lot of people misinterpreted this study as we don't have to do anything about temperature management, and it's taken us a long time to get back to people saying actually you do have to manage temperature, but if you manage temperature it's not that important what you manage it to, whether it's 33 or 36 degrees. So what that study showed was that if you cooled people to 36 or 33 degrees, it didn't make any difference in terms of survival. But what people in Australia tended to ignore was that all of those patients had really carefully managed temperature, and all of those patients had very controlled post-resuscitation care. So what these study results don't say is don't worry about targeted temperature management. They've just given us a little bit more leeway in terms of the target temperature that we aim for. So the take-home messages are really to prevent cardiac arrest in the first place, if you can, by early recognition and responding to deteriorating patients, commencing chest compressions as soon as possible, and if the patient's unresponsive and not breathing normally, push hard, not too hard, we heard yesterday. If you can work out where 6 centimetres is, well, don't go past that, but if you can't, push hard, push fast, don't stop, don't overventilate, and do the basics well. So I think it's really easy to be distracted by some of the sexier interventions that don't have a strong evidence base. So, we need to focus on those interventions that we know work. And I think importantly, as nurses, resuscitation doesn't stop when you get return of spontaneous circulation. So that's a happy time for all of us, but we've still got a lot of work to do even when the patient does achieve ROSC. I just wanted to let you know that our colleagues from New Zealand are having a conference in 3 weeks' time in Auckland, so if anybody fancies a trip to New Zealand, here's the details of their conference and you can certainly go to their website. Thanks very much.